Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight, our special guest is Dr. Drew Rixon from Tennessee. He received his optometry degree from PCL and completed a postgraduate residency at West Tennessee Eye. He's a fellow of the American Academy of Optometry, a diplomate in glaucoma, a member of the Optometric Glaucoma Society, frequent lecturer, author, peer reviewer, and is on the editorial boards of Clinical and Refractive Optometry and Clinical Insights in Eye Care. He has been our special guest on a number of events. I love how he puts together presentations. He is so well researched. He is so experienced. He brings a wealth of knowledge to these talks. I really enjoy listening to him. It's really a treat for me to have Drew, who's a good and close personal friend, to do these meetings, both live and virtual. So please, a nice warm OEC virtual welcome for Dr. Drew Rixon. Drew, take it away.
Great. Thanks so much, Joe. Really appreciate everything you guys have done for me, both you and Greg, and appreciate Vanessa's help behind the scenes. We'll try to get as much information in here tonight as possible. You see, I'm a diplomate in glaucoma, but the reality is, glaucoma involves the nerves. So, there's going to be a lot of nerve-related conditions that we're going to be dealing with. In part one, we talked about some IIH, there were some tumors, CRAO, and some ophthalmic emergencies. And we're going to get into a couple more things similar. But Greg loves talking about, functional medicine. He's an expert in that. And there's going to be a lot of mitochondrial talk here tonight, which he'll have an opportunity to obviously jump in. And obviously, I always like us having, conversation, even sometimes discourse, because I think it really adds to the overall slate we'll be providing here tonight. I don't have any relevant financial disclosures here on anything we're going to be talking about. There'll be different OCT platforms that will be discussed, mainly based on the software characteristics, but I probably won't necessarily opine one way or the other. In general, how I tend to present is I'll kind of start off with kind of a core topic, and I'll kind of branch off at times if I think there's a good teaching case or point, or there's something that I learned that I thought was impactful for me. So I'm going to try to squeeze every drop out of everything, whether you find it redundant or not. So hopefully it's useful for you. Now that we have more and more technology that we're integrating into our practices, the term multimodal imaging, which has probably been out for a decade now, really becomes foremost, where we want to look at the different instruments, we want to integrate them, we want to make sure that we best understand what individual disease process we think is going on, so we can then confirm that and appropriately treat our patients and maintain their vision. And always, as the technology comes along, the nomenclature changes. So we'll talk a little bit about that with MacTel. We'll start off with case TC, and case TC is kind of a rough case, a very sad situation. I do want to acknowledge one of our former residents, Dr. Sierra Unruh, spent most of the time with this patient towards the end of his life as far as the care from an optometric standpoint. So it kind of sets you up with that, how these things can play out. So this is a 30-year-old male. When he presents to one of his last exams with us, comes in for a comprehensive eye exam because he was referred by the PCP. And the PCP and he were talking, and the guy says, "Hey, my vision's reduced." The PCP does a good job and sends a consult over to us. This is a sad state. Like I said before, this kid started heavily drinking at 16. There was some physical abuse in the household. There was absolute alcohol and drug abuse by the parents. And so there was just kind of a gateway situation into how he ended up where he ended up. He was in inpatient rehab in 2002. And then after he got out and was, ostensibly clean at the time, served overseas, enlisted in the Army, served overseas in Iraq for one tour post rehab. And then, post deployment, he's been drinking a fifth of rum or vodka a day, 10 to 11 beers daily, smokes half a pack of cigarettes per day. Typically, when the residents or students come in and we're talking about this disease entity that we're going to talk about, I'm like, "Oh yeah, he's drinking a fifth a day," or something like that. Are they drinking like a fifth a day? They drinking a handle. And it's like, "What are you talking about, Rixon? I have no clue." Well, a fifth of vodka is right there. In college, I had a friend named Nico, and one of the cheap vodkas was Nikov, and we would just white off the V, and that would be Nico vodka. Okay. So super cheap, but something that this guy would probably be drinking. When you're drinking a fifth of vodka a day, that's essentially 17 or 18 shots coupled with 10 or 11 beers. So this guy is really, really, really drinking. This isn't someone that has some consumption of alcohol, and it does make a difference, especially, genetics, epigenetics. This is an epigenetic nightmare right here. So the last comprehensive eye exam, because this dates back to probably 2015, 2016, comprehensive eye exam showed this guy was completely fine from the standpoint of visual acuity, which, again, Snellen acuity, dies hard. I mean, there's obviously better ways for us to assess visual performance than Snellen, but this is the information I have, right? So medical history wise, alcoholism, insomnia, PTSD, and that's not just a military related PTSD here. He's got AFib as well. This 30-year-old, so his cardiac system's already in trouble. He's having more neurological complications with seizures. He's got a TBI as well, taking antidepressants, and you're taking all these medications, and his PCP and his drug alcohol counselors are like, you got to stop doing this because these are just exacerbating your nightmares. But the only thing that can mollify him at this stage of his life with all the stuff he's experienced is drinking and drinking and drinking. So by the time he gets in and sees us in what I think was his last exam, was he was count finger at 4 feet in both the right and the left eye. And, probably wasn't very, very specific on that, but he's count finger. So, he's obviously visually debilitated. B12, when we look at the B vitamins, they're wholly just massively important in cellular metabolism. As far as mitochondrial function is concerned, there has to be some supply of energy to help drive a lot of these cellular processes. B1, and these numbers aren't necessarily important. You don't have to memorize reference ranges of B vitamins, but the numbers that he's presenting with in his most recent blood work are actually theoretically normal, although there's a drop off from B12 from 960 to 480. You see that drop off, it's still normal. So, you can't always capture what has gone on based on blood work. Vitamin D was okay. And this guy's blood alcohol level is I mean, it's mind-boggling. You think of like the legal limit in Tennessee is 0.08, which is 80 milligrams per deciliter. This guy was getting up to a 0.486 at times. And concentrations over 400 can be lethal, and unfortunately, ultimately were. So his folate was low, urea nitrogen levels were low. When we look at nerves, I think in general, there was a paper that came out recently that was a commentary editorial talking about how to look at nerves. And it was talking about you really got to be careful, and clearly this isn't glaucoma, but you really got to be careful looking at the features of the optic nerve rather than getting caught up in certain risk factors. So when we look at this optic nerve, the first thing we're going to do is take kind of a gross approach to it and avoid the cup to disc. Because sometimes what will happen is you'll have a preconceived notion of what a cup to disc is. Because when you're looking at any nerve, a lot of times glaucoma is at the forefront because it's more common than some of these other neurological entities. So if we were to look at this nerve and go from the outside in, and let me go ahead and pull up my laser pointer here. So if I'm looking at this nerve here, we're going to look at the size first. I get it's a monoscopic photo, but generally speaking, you have a large nerve. You look at the large nerve, can't really tell what's happening to the nerve fiber layer. You look at the rim from 12 o'clock down to 6 o'clock. It looks pretty normal. Central vessel trunk looks normal. Lamina looks normal. And then obviously you see the pallor. And you see the pallor going from 6 o'clock to 12 o'clock in a very, really nice, clean hemispheric presentation. This isn't really, portional segment sort of thing like you might have in, NAION or something like that. On this left eye, you look at the temporal hemisphere again, maybe not quite as encompassing of the entire temporal hemisphere, but it's taking up enough that you can say you got a bitemporal defect that's going on here with the nerve, and you don't have a loss of lamina tissue. It's alteration to the neural tissue on the rim. So let's go on to radiology. And this was something we already had with him because, cerebral tissue, nerve tissue, it's theoretically all the same. When we look at some of the stroke guidelines, it's considered to be the same. So let's see what's happening with this young man. And I want to just review quickly that you have, sulci and you have dry eye. When we look at the cerebral cortex, It's not this smooth brain thing like some of the Gen Zs are talking about. It's literally got some undulations to it. And you're going to have gyri that's made up of cerebral tissue. And then you'll have the sulci that will separate. And this is just kind of a illustration showing these various sulci that will separate the various portions of the brain. So this is more or less a normal brain scan of a 40-year-old that I think I took from one of our other patients. So I took online. Actually, it must be one of ours because I don't have a citation on it or a link to it. And you just take a look at a normal sulci right here, or sulcus. So a normal sulcus is deep. You look at the ventricles. I think that's always a good way to look. And this is, pretty much a midline slice right here. So the ventricles are pretty normal in caliber, and you don't have like an overabundance of CSF relative to what you would expect. Okay, or it is what you'd expect. Whereas this young man, if you look about it over here, what's happened is you see the size of the sulci here. And granted, this is not a slice that is comparable here. This is more left-sided than it is midline, but it tells the tale. I think this is the most obvious one for me. So the sulci have gotten wider and they have gotten more shallow, and that's kind of by subtraction, because the cerebral tissue has just shrunk. It's atrophied. This guy's brain also, you look at this, you have ventriculomegaly, and it's not because there's too much CSF being produced or there's not enough CSF draining. It's because this guy has something called ventriculomegaly ex vacuo, where you have all this atrophy of tissue and the ventricles seem much larger. The cerebellum, if we went through across it, is probably going to be shrunken as well. This guy's not doing well with his balance. He's working around, barely getting by. So just a sad case overall. And this is just trying to highlight the difference with this sulci. So this guy is the brain of a 90-year-old that was in bad shape, most likely, and he's only 30. So a sad situation. When we look at the fields, and this was obviously not done when he was count finger. We're not going to try to do a field on someone that has count finger vision. So maybe back, a couple of years before, we probably saw that bitemporal pallor and we studied it accordingly. When you think of nerve damage, I think we like to memorize these different scotomas, like, it's an arcuate, and Joe had the pronunciation for germ, which was correct. It was, I forget what was it, Joe? What's the correct bajerum
It
or
isn't,
germ?
but it isn't Budgerum or Jerum. It's Biarum
Okay,
scotoma.
I couldn't remember. I got to brush up on my Swedish. I'll have to work on that. But you think of these. There's a myriad different field cuts that you can have with the nerve. So we teach like a secocentral because obviously the nerve is here, and you work your way over to fixation. But you can see also there's inferior arcuate damage, bundle damage as well. So trying to, aside from answering a test question, mimic what should be happening, it comes down to, does it make sense? And so one way for it to make sense is try to figure out, where is this nerve relative to where I'm sampling it on a field. So the Hood report's a good way to do this, because what it does is it superimposes the various visual field loci onto where the retina is that it's going to be sampling. So if we look at this guy's nerve, it would be right here. And so if you think of how the overall sampling really is, it's not that good with a standard 24-2, just as a side note there. Okay. But it kind of allows you to localize and orient where you are going forward. So just always wants you to make sense of the field defect, and don't memorize patterns. See if how the field is sampling the tissue makes sense with how the tissue is damaged. Just as a quick teaching point, I wanted to throw that in there. RNFL is diffusely thin. You don't need to be good at looking at reference databases, which again have limited utility. The main thing is looking at the tissue. So the tissue here is very, very, very thin because his RNFL is in bad shape, because his neural tissue has been damaged, because his mitochondria are not functioning at a very high level, if at all, anymore. This is another case, and the value of putting in this other case is just trying to talk about where we have biases. So unfortunately, what will happen sometimes is that in eye care, sometimes we just don't think, we memorize things. And so a case like this, we have someone that has been heavily, heavily, heavily consuming alcohol with very, very little nutrition in their day-to-day. And they have this damage to their mitochondria, and they have this optic neuropathy. And then we do scans. And then all of a sudden, we take Goldman. which has been around since 1955. And then we get a pressure of 22. And then we somehow turn this into a mixed mechanism glaucoma suspect or something like that. That doesn't make a lot of sense. And so when we look at systematically at the nerve, we want to look, is there neural tissue damage, or is there also connective tissue damage with that neural tissue? And a great study I always like to show is this Claude Burgoyne one, where they kind of dissect through a nerve. This is a postmortem reconstruction. It's a great article if anyone wants it. And so a normal nerve is going to have these boundaries. You're going to have ILM, which is in black. You're going to have the anterior lamina, which is this green here. Brooks membrane line is a good termination point of retina going in, and sclera is going to meet that area right there. And what you see here is all of this tissue right here is neural tissue. It's prelaminar neural tissue. Lamina is connective tissue. So if we look at this in a little bit more detail here, this is a nerve that, let's say, has had an NAAION. I get it's blanched out here and washed out. It's not overly compelling. So you have to kind of go off of what I'm telling you. When we look at ILM here, ILM initially was with this pink area. But let's say there was an NAION, there was some sort of infarct that occurred, axoplasmic stasis, and subsequent damage to the nerve, specifically neuroretinal rim. Then you have the astrocytes laying down, all that stuff, right? And so you have a shrinkage or contraction of just prelaminar neural tissue from here to here. You see down here, lamina, anterior lamina specifically, is in the same place. When you have glaucoma, you have deep laminar cupping, you have loss of connective tissue. So don't try to overly complicate these situations. If someone is programmed to ultimately have glaucoma, genetically, they're going to end up with glaucoma, even if they drank themselves to death. But in this case, this patient just has a mitochondrial optic neuropathy overall. And this is what glaucoma would look like, where you have really excavation, and this is a dramatic presentation here, but you have, posterior excavation, very little lamina down in here, very little prelaminar neural tissue, because you lose both neural tissue and connective tissue. That's what that's going to look like. And then if we look at a quote unquote toxic optic neuropathy, which is, I think, a term that is still floating out there. I'm going to try to see if we can kind of think through maybe rephrasing that tonight, but that's what that's going to look like, your toxic optic neuropathy. You can see that again, lamina, the anterior laminar surface is here, and all this prelaminar neural tissue is intact, although, chewed up, for the lack of a better term. Doesn't necessarily look all that healthy. So just as just a side teaching point on that, because unfortunately I see this frequently. I think there's a tendency to try to turn things into something they're not based on risk factors. So historically, we'll look at a toxic and nutritional optic neuropathy. As what happened with TC, it was bilateral, it was painless. He experienced more than a fog. He got to count fingers. Now, again, I don't have this time lapse of how he played out as far as what his symptoms were. With the alcoholism, he fell off, for a while, and then came back, going from probably 2020 to count fingers. So there's a point at which, we lost him. So the time course is going to be different based on every single person. What are they consuming? What are they not? Taking in from a nutritional standpoint, what are their genetics? How is that all going to play out? Because I think overall, when we talk about, toxic optic neuropathy, it tends to be, in my opinion, probably more rare versus the number of people that are consuming a lot of alcohol in this country. We can look at color vision, usually it's a red-green deficiency based on the old, Kollner's rule. And then overall presentation may actually be asymmetric. You may just get to the end point and not see how it actually played out. So again, you end up with bitemporal pallor. So there's a wide range of field defects, as I said, and that's just a little, kind of breakdown table here. And the risk factors are, there's multiple substances, obviously, that can break down cellular function. The mitochondria, especially in that papillomacular bundle, are really, really, really low on energy production relative to the amount of energy consumption that they need in order to drive that area, why it's so susceptible. So a lot of these agents can create issues. If we get to it later, we'll talk about a case with a patient with AFib as far as medications that could rarely cause an optic neuropathy from that standpoint. So let's go to our first poll question. And I've already set you up for the answer, what I think the answer is, but please be honest, even though I've tried to sway you. When I think of toxic optic neuropathies, the first thing I think about is mitochondrial damage.
The polling question is open. Let's see if we can remember. It's the second one down. It says chat polls. If you're not seeing it, just click on it and then you'll be able to put true or false.
Any initial thoughts, guys, on any of the conversation? Any you words of wisdom for any of this subject?
Well, if you go back a little bit, Drew, we yeah, that's good. I mean, toxic nutritional, it isn't one or the other. It's sort of the combination. It can be what you're taking in, toxin in terms of drugs, directly neurotoxic, or it's a lack of something they need because of something that they're doing. People who are alcoholics tend not to eat well. People who are alcoholics tend to smoke too much. So you're putting a lot of things together in this milieu of damage to the papillomacular bundle. So you've got the person who is kind of self-inducing, and then you'll have people who are inadvertently self-inducing because of medication use. I'm sure you'll probably talk about that in a little bit.
No. I mean, it's absolutely true. It's a perfect storm, and there's a lot of things that have to conspire in order to result in the unfortunate reality that this young man experienced ultimately. Do we have the poll
And
results?
I do, but I'm going to make one
Yeah.
comment to add on is that in any nutrition that that person that you and Joe just described, the body triages. So if you remember, triage comes from a war. Is when the war is over, the medical team runs out, and the person that's dead you can't revive, but someone that's just slightly wounded. Triage, try meaning three. They try and put a tourniquet on, save someone's life. So the body triages all the time. So what little nutrients that person brings in, it goes to kind of fight off all these bad vices that the person has and never gets to the tissue to do the nutritional side that it's supposed to. So I always say, like, I'll watch people eat at like the Marriott. They'll have this great like antioxidant breakfast, and then they walk outside and have a cigarette, and the body just triage. It's not going to put those nutrients into the eye, into the brain, it's going to try and go out and put out those toxins. So two little thoughts there.
No, I mean it's a valid point, and I think at the end of the day, even though we're very eye centric, the eye is expendable as far as keeping the body alive. The eye is expendable, unfortunately. So the
We've
current
got
thoughts.
70, we got 77 people here saying when I think of toxic neuropathies, the first thing I think about is mitochondria damage. 77% went for that, Drew.
Wow, thank you. I appreciate that. I'm not gaslighting you up here. I mean, we're actually like trying to tell you what the new thoughts are. So that's great, fantastic. I mean, so the current thoughts on pathogenesis is still that it's not really fully understood because, as Joe was talking about, I mean, it's complex. There's a lot of things that have to conspire for there to be damage. And the primary lesion is I think we tend to think of it as the nerve, but the nerve is a bigger place than I think we think about. It could be the optic tracts, even chiasm or retina, where you're having that triage that's going on. There's multiple substances that likely affect the optic nerve, the papillomacular bundle. And it's directly accepted that the common pathway is mitochondrial injury. So, unfortunately or fortunately, I've been spending a lot of time on the electron transport chain this week and just looking at any sort of oxidation, reduction, imbalance that occurs, free radicals, breakdown, fragmentation, and stuff's gonna die. There's gonna be cell death, and if you're in that retinal ganglion cell area, as far as those axons terminating, ultimately, going down towards the chiasm and the tracts and all that other stuff, you're gonna have some issues, and it all comes down to homeostasis overall. And if there's a breakdown in that, the eye might be susceptible. And so it's probably more reasonable to call these under not even the umbrella of toxic nutritional, but you just go that, hey, there's mitochondrial and acquired mitochondrial, because I think we think about like Leber's or autosomal dominant optic neuropathy, like the RPE65 with some of these RPE65 sort of scenarios that are going on. So it's probably a mitochondrial optic neuropathy overall that we should be thinking about, because like what's being damaged overall. So that's it. That's your mitochondria. And you think of all the different things that are in here. There's sphingolipids in the membrane, which we'll talk about later. You know, you have coenzyme Q10. I actually just got some in from Amazon that I'm going to start taking tonight, because I was looking at the electron transport chain so much, maybe a little ridiculous, but it's, I guess, my reaction to all of this. But all of these different, portions within this chain that's in a mitochondria that can break down, and then there's not enough energy, and it's wanting to consume all that energy, you're in trouble. So the thought process again is that RGCs have some of the greatest energy demands in the body. But what you have here, and I'm going to actually pull up this right here, is, you go retrolaminar right here, you have myelinated tissue. It's protected. When you get into this, you anterior to lamina, papillomacular bundle, you have all these mitochondria, but they're not really protected. They're trying to produce energy. They're trying to use all that energy in this area. And if there's any breakdown, you look at creating reactive oxygen species, you have a decrease in production of ATP, and you're already maybe susceptible because you're not protected, because you're unmyelinated, you end up having apoptosis, or I was always taught apoptosis, that the P was silent. Actually, we got into this at work the other day, and actually found the original article where they actually said the P should have been silent. But I think a lot of people will say apoptosis, but the main thing is, again, these cells aren't popping, they are necrosing, or they are, dying, they are atrophying. So ultimately, this papillomacular bundle just sets up perfectly for damage from toxins ultimately. But it is, I think overall it's fairly niche. Now, I had one last week that I thought was kind of interesting that I figured I'd throw out to you guys, talking about that it's not necessarily always going to be these isolated nerve thing. There could be more at play. So this is a case where we have pretty clean hemispheric pallor on the right eye. This Optos image is not great. You can maybe make an argument. Clinically, it did look like there was some pallor over there. So you have this asymmetric bitemporal pallor. This patient's a 75-year-old drug, alcohol, cocaine abuser, very bad vascular dementia, in a wheelchair. I'm not sure how we were able to get the images, but we did. And this is, what his brain looks like. So you don't have to know much about looking at MRIs. MRIs talk in terms of intensity. You can see that right here, there is a lack of intensity. You have a hypointensity. You have huge ventricles here. This guy has very little brain tissue left whatsoever. Frontal lobe is atrophied. He's not functioning at a very good level, very, very advanced dementia overall. We look at another view. Radiology says, and I couldn't get a good chiasmal view, but the nerves are very, very small in caliber overall. And then ultimately there was a major amount of chiasmal atrophy. And then you can look also in here with this hypo-intense regions, and really look at your white matter here. The white matter should be up, filling all of this space, which it's not. And this is, I think, just a terrible shot as well here, where you see on that T2 as well, you'll end up having these signal abnormalities that are consistent with really long-standing small vessel ischemic disease. And so I think that in this particular case, and I'll see what Joe and Greg say about this, this is probably a sort of a dieback situation back to the nerves. But again, it's a complex situation. You can't say all the time what's happening. But this is not someone you're going to work up for some nutritional optic neuropathy. Life expectancy is low, and brain looks like this. So I don't know. Any thoughts, guys, on ischemic chiasmal atrophy and dieback?
There's a lot of ischemia here. There's loss of brain tissue. The brain is the back of, the back part of the eye, and the eye is the front part of the brain. So I don't have any suspicions that there's anything else going on here other than just widespread neural atrophy. We can see it in the cerebral cortex, frontal lobe, chiasm, optic nerves. I mean, the optic nerves are atrophic even on the imaging. So I think this is all a generalized end of life neurological event.
And again, what contributed to that, Greg turned me on to the book Outlive, and one of my residents reading it right now. And there's a lot of talk about health span versus lifespan. And this man's health span has not come anywhere near close to his lifespan. And a lot of his behaviors, and a lot of it could have been induced. This was a veteran that had potentially a lot of nightmares and traumas in his life, and there may have been some coping mechanisms that were not ultimately good for him. But again, this is what we're dealing with here, so it's not always just going to be something you can obviously blame. It may be a more diffuse thing. It's interesting because in the past we used to think of alcohol as being a directly neurotoxic to the nerve. It's no longer thought to be that. As Joe so nicely said before, this is really just the amount of lack of nutrition going on, coupled with the person imbibing the amount that they're doing. This is something that is, I think, on the decrease overall, depending on what population you're working with. Us Gen Xers tend to drink to solve our problems a lot of times. Gen Z, not so much. Millennials, maybe not so much. There had been a massive rise during the pandemic, and some of those people may, in fact, have turned into alcoholics. So this is something that you may see in your practices. Luckily for me, at one of my jobs, we have a lot of drug alcohol counseling support groups that are readily available, but it's something that you have to figure out in your community whether you can help help aid these patients, because again, as optometrists, we may be the entry point because they may start noticing some sort of defect, some visual sensitivity loss, or something that's something that's indescript for them that they can't really describe to you, but that things are worse. So that may be the entry point where you can help these folks. The decision tree, I think some of the stuff isn't really necessary. We've talked about. So, mitochondrial optic neuropathy, is it a diagnosis of exclusion, as our next poll question? And I really do think that diagnosis of exclusion is another one of these buzz terms. Oh, it's a diagnosis of exclusion. And I'll just leave you at that, and I'll expound upon that here in a second.
The poll is open, and no one's responding yet. Do I have it open? I do. Okay, they're responding now. Okay. Mitochondrial optic neuropathy is a diagnosis of exclusion. True or false? Joe, anything in the chat box?
There is nothing in the chat box.
Oh. Well, the trend is pretty well set here. You're split on this one, Drew. Exactly 50-50 right now.
That's great. That's fantastic, actually. Because I do think it's nuanced. We throw the term out as this blanket diagnosis of exclusion, and I think we then go down this pathway of you need to do the $52,000 workup and bankrupt the person. And it's like, what is required as a physician to achieve exclusion? And each of these individual entities will have their own, requisite need to exclude, and what does that involve? So I think in a case like this, where we had everything lining up, why am I going to put this person through, syphilis testing or something like that? And we probably already had access to a lot of that stuff. So a lot of it's going to be context driven. So I like the 50-50 because I think you could probably take both sides of that coin and turn it into something. I don't know. Any thoughts on that, Joe, Greg?
Well, when we're looking at this, I'm not going to call it a diagnosis of exclusion because there are certain things that we can do. When we look at it, a bilateral, relatively symmetrical presentation. All right, that starts to narrow it down.
Yeah.
Now, are there things that you can test? Now, if you're looking at optic neuropathies, I do think that neuroimaging the optic nerve is often very important, and that is imaging of the orbits and chiasm and the brain with and without gadolinium, with fat suppression of the orbit if you're talking about optic nerve, because there's 4 parts of the optic nerve, and that's one way you're going to get all 4 parts of the optic nerve. But you can also test and you can find out that they have, we look at what their blood alcohol is. We can see what their folate level is. We can see what their B12 level is. We can look for some toxic metals. And when it comes down to those things that we can find on some relatively simple blood tests, it's not really so much a diagnosis of exclusion. It is a clinical diagnosis that we can find support for.
Yeah, I think that's a great way to put it. And you know, you can find support fairly easily in a lot of these cases without going to the ends of the earth.
Yeah.
So this is one that Andy Grower taught me as a third year. So I'm going to give Andy credit on this. I don't know if this was something that was swirling around PCO when you guys were there, and who I can attribute this to, but I'll give Andy credit on this. And so when you're going through this, you're trying to support whatever you think it is, you can work through various mnemonics, you know, and I'm not always huge on mnemonics, but I think this one's a good one for the nerve. You know, do you have a vascular ischemic situation? I think you could argue what was playing out in this guy that, you know, ultimately there was probably some ischemia that was going on there. Do you have an infectious condition going on? And, you know, with a bilateral nerve head situation, depending on how it's presenting, it might be reasonable for you to rule out syphilis. I mean, I got some great syphilis cases that we can do at another time. Nutritional, toxic, you know, mitochondrial optic neuropathy. We have the smoking gun in this particular case. Everything's laid out for us very nicely. This was not an overly challenging scenario, but sometimes they can be. Do you have a demyelinating disease? Do you have inflammatory or immune? You know, the immune system is, as I always say, a fickle beast. I mean, you don't know what the immune system is going to do at any given second, you know? So that's something to think about there. Traumatic, self-explanatory, compressive CSF, chiasmal masses that we did last time. Is it hereditary, metabolic? And then, you know, do you have something degenerative? So I think if you employ something like this as a mnemonic, just like you can employ, you know, questionnaires in uveitis and stuff like that, it helps you narrow things down and maybe target your testing a little bit more meaningfully. So you're not just sending someone out for, you know, taking a vat of blood from them and you know, just then needing to go ahead and transfuse them after. It's kind of ridiculous, some of the things that we do, where we just roll over to wills and we do everything known to man. So the basic testing on something like this is, you know, go through, you like you said, the heavy metal exposure, toxic exposure, a good history. You know, I was always taught that history was the most important test you would ever do, and it is never ending. So, you know, as you're going through that examination, it may spark more things, the conversation. So what's happening in this case? You know, diagnostics, you know, sometimes you can have, like if you're to do the color DX, it may detect something prior to standard Ishihara or any visual acuity changes first. Macula is critically important because the neural tissue from the macula, from those ganglion cells, that's what comprises the neuroretinal rim. That's what comprises the neurofiber layer. So it's important to look at macula. Neuroimaging, I think, is absolutely necessary. And then the lab work is, in a case like this, you know, basic nutritional panels. Now, it depends on where you're at. At work, I can go ahead and order with impunity. You know, it's like, no big deal. Let's order a whole bunch of blood work and nutritional panels. I was looking at Quest and I was looking at LabCorp the other day, and you're talking on different nutritional panel composition or compositions to the panels. And a basic one was 200, and it might be going up to $400. So we do have to understand in the private sector, depending on how insured our patients are and whether the insurance will pay for it, you know, is it a necessary test to understand what's happening in this particular case? So just food for thought there. So that's it on case TC. Any final comments, questions, concerns?
Yes, if you can go back 2 slides, Drew, I'd appreciate that. Okay, now for the audience, you may not feel comfortable working these patients up yourselves. You should only practice at your comfort level. I like this. This is what I do. To me, a scleral lens is a moon. I just referred an RGP out to another colleague. I don't do any of that. But if you think, well, I'm just going to ship this to the ER, okay? What ER physician is going to be able to work through this without any help? And if you get ophthalmology, it might be a PGY1
2 or something, yeah.
like a first-year resident.
Yeah.
So it behooves you to think about this and do what we do best, because once it gets downstream, none of this happens. If you go forward one slide, please.
Yep.
All right, look what we do here. What can we do? OCT, nerve head, OCT, macula. We can do pupil testing. We can do perimetry. These are all things that we can do that will not happen when they get downstream. And when you start working with the optic nerve, the most important thing I can tell anybody to do is always get a field.
Yeah, I think that it's really, and we've talked about this before, it's easy for me to prep a lecture and look like I'm an expert when I'm lecturing, right? The reality is the real world's much muckier than this. But you have to start somewhere. So these things can seem overwhelming, but you have the basic techniques to at least start understanding what's going on. And if you are going to send out, which I think, again, the only reason to not send something out if you're unsure is your ego. That's the only thing that would prevent you from sending anything out. So if you want to take care of the patient, at least get the basics done so you can go ahead and help out the person you're referring to. So there's some, at least some sort of a baseline to work off of. But again, I think this is just the reality. And, we can be good at neurooptometry, but it's a context. So not everybody on here is going to be, wanting to do this. And again, I've got one of my classmates that's just really badass at scleral. So if like Boaz is going to do a scleral, it's like, hey, go up to Baltimore and see. I mean, I'm not going to fly someone up there, but I can contact him. He can contact me. So there's also, a network of colleagues you can work with on some of these cases if they're not urgent. All right, so I'm going to go ahead and move on to case TRI. So we do teleretinal imaging where I work. And so this was a case that was initially seen on TRI. Well, TRI is done for diabetes. I think, I always like to talk about anchoring bias. So if I'm just sitting there all day long, just looking at photos for diabetes, I'm probably going to potentially distract myself from any other reality. But when you look at this and you look at these eyes, and looking at retina, you can either dissect it hemispherically, horizontally, you can dissect it vertically. I don't care what you do, break it down so you're comparing the various sectors. And when you look at something like this is clearly not a diabetic thing. In your notes, there's another case that has a more pronounced potential overlap with diabetes, but in lieu of efficiency, I want to dispense with that. So go with this. So you have this loss of transparency, this whitening on this temporal side of the fovea, and if anything, more so on the superior temporal area right there in a diabetic that's 62. I want to talk very briefly about fundus autofluorescence. I always like to sell this technology. I think it's very, very important. If you have it, you're missing out. If you haven't, you're not using it, you're missing out. So essentially what happens is if I inject fluorescein dye into your arm and it travels from the veins up into your veins in your eye, and I use an excitation wavelength that corresponds with the wavelength of fluorescein, then it's going to excite and I'm going to get fluorescence. Well, I don't necessarily need that all the time. I can use autofluorescence where I don't have to inject the dye. So in the eye, there are fluorophores, specifically lipofuscin. They're most prominently found in the RPE. So if the RPE is damaged and the fluorophore is exposed, I use an excitation wavelength that will excite the exposed lipofuscin. It will emit, and then the machine will capture that, and there will be a brightness map. But where it becomes important with the disease entity I'm about to talk about is that blood vessels do not have any autofluorescent properties as far as hyperautofluorescent. They are hypoautofluorescent. So there's not going to be anything that's excitable about erythrocyte when I put down something that should be at a wavelength of lipofuscin. So when you think of using the autofluorescence, we think of AMD, we think of pattern dystrophies, we think of also IRDs, we think of I don't know what else we would even think of right now. I guess a pachychoroid spectrum would show up. You'd be able to delineate some things, but you can also look at it for some vascular issues as well. So we look over here and I can see pretty pronounced that these vessels are behaving in an abnormal format, and that will become relevant in a little bit. versus the technology that we all have on all of our scans. If you just do a nerve head scan, a lot of times you'll end up having this near IR, which is a near infrared, and that does a good job for deeper tissues overall. FAF is useful for both superficial vasculature views as well as what's happening at the RPE level. So just some food for thought there. And getting into multimodal, we've used FAF, we've used NIR. We have two depictions of what we think is going on. Now we go to the cross-sectional scans. And then, Greg and Joe and I were talking about before about the ellipsoid zone and the mitochondria in the ellipsoid zone, and it being pretty much a biomarker for what's happening with the photoreceptors. It's a surrogate measure for the photoreceptors. So what I want you to look at is see how the ellipsoid zone is right here, and then how it's going to go ahead and terminate right over here in that subfoveal region. Not to mention you have this hyper-reflective area here. So when we talk about OCT, we talk about reflectivity. Pigment is really, really hyper-reflective overall because you have all that reflection that's occurring. We'll move on to this slice. What you have here is you have this area that is densely hyporeflective. So there is nothing at all that is reflecting in that area. So that could be space, it could be fluid. And I'm going to tell you right now that we have a tendency to just think that anything that is black, more or less, must in fact have fluid in it or it's cystic. That is not true. These are actually areas of degeneration. And if I did a fluorescein angiogram, nothing would show up in that area. That's just space. It's a cavity. We're going to look at these OCTs on this case on the left eye, and we have more of the EZ zone loss. And it becomes really important as we get medications that will be able to take care of things like this. So the EZ zone is something that you really want to look at. They used to call this the photoreceptor integrity line. You look at RPE. RPE is probably the most densely hyper-reflective line that you can orient off if you're first getting to work with OCT. I like to orient first off the outer nuclear layer, though. That's an avascular layer. It's pretty consistently, homogeneously, I guess, hypo-reflective for the most part. I think it's a half empty, half full scenario there. You could argue that it's minimally hyper-reflective, but that's a pretty consistent area to work off of. But pay attention to this ellipsoid zone as a surrogate for what's happening with the photoreceptors, which are obviously critically important to our vision. So we look as this disease progresses, we now have hyper pigmentation that's going on here. We have something called a right angle venule. We have these parafoveal superficial crystalline deposits, and then you also have a loss of transparency in this one sector. Now, this person's diabetic. You do have a hemorrhage there. Is that going along the nerve fiber layer distribution? Yes, he's also hypertensive. Mike White, I think, is on here, and Mike and I work together, and we talk about a lot of these retinopathies are most likely multifactorial. We tend to just end up being splitters and say, oh, this has to be primarily diabetic, or this has to be primarily hypertensive. And there are definitely phenotypes that are absolute on both of those. These patients have multiple conditions going on that are vascular, and there's going to be compromise to that vessel physiology, just as an aside. So at the time, we didn't have OCTA. Fluorescein angiography was done, and the fluorescein angiography does a very nice job delineating or elucidating what's happening at the vessels. So you can see at these vessels right here, these paravoveal vessels, you're seeing dilatation here, and you're getting a little bit of, leakage going on early on. You have a little bit of dilatation there. You have some telangiectasias. And these have been described as either diffuse or mixed or focal. And as time marches on, as we have more and more fluorescein recirculating, you're going to go ahead and have more hyperfluorescence, and you're going to end up being able to see with more, more clarity of what's happening on. So you have this telangiectatic end bulb, and then you have this just kind of not like you have a major leakage like you have with like a DME or CME. You just have this kind of light leakage that's going on, like there's compromise to tissue, but it's not necessarily really blowing up. I'm going to move past this left eye because I do want to make sure we're covering enough ground. This would be another example right here, which was in your notes, where you do have a microaneurysm, presumably might be a heme. We'd have to cross section through that. You have some areas that look like they might be exudates. It might be something crystalline. There's some overlap presentation. You have potentially some drusen there. And then you see the vessels are abnormal. But if you're just looking at that person and they're diabetic, I think very few of us are going to say it's anything more than just diabetic retinopathy. You have mild retinopathy. You could argue for some exudation. You might go ahead and advance that up to a moderate stage. You might do some cross sections. And that's where the cross sections will kind of give you a little bit of a clue that this isn't just a diabetic situation. I do want to talk a little bit about these. When you're looking at diabetes and you're looking at diabetic changes, you can have diabetic retinoneuropathy. The argument would be that the minute you're diagnosed with diabetes, you probably already had diabetes, and there's probably potentially already some nerve damage going on. And I don't think that's overtly controversial to say that. So what you have here is a wedge or a slit that's more consistent with a diabetic ischemic condition versus glaucoma. There's a tendency for us to conflate wedges or to attribute a wedge to only be glaucoma. Glaucomatous wedges are usually more like from about here up to about here. They're much wider in their overall angular width. So just food for thought there, since we're just kind of going through this case. And then
Actually,
oh,
Drew,
sorry,
if you go
Yeah.
back, it looks superior temporal. Looks like there's a second wedge right there.
Yeah. We got a bunch actually, and you could argue for a little tiny one here as well. And even though these go into the nerve, and this is unfortunately absolutely blanched out because I wanted to highlight the wedges. This nerve is not a nerve that's damaged from glaucoma. Again, there has to be some sort of glaucomatous features of glaucoma. And me picturing saying something like the students or the residents, like, there's bayoneting there and there's some vessel deflection. It's like, yeah, these are like buzzword terms. Like there has to be some overall phenotype that has features of glaucoma going on here. So be careful looking at the total picture and understanding context there. But yeah, there's a bunch of wedges that are present there. And then again, this does a better job just highlighting the telangiectatic vessels that are going on there. And OCTA would be something that we'd be able to use now. I think that in using our individual platforms, we have to understand what are the capabilities, and what are those capabilities and how can they allow us to demonstrate to our patients what's actually happening. Because a patient may come in here and you see this temporal hypertrophy of RPE that's here and ostensibly some damage there. And this patient in the right eye, I don't know why this would happen, but maybe they're starting to notice something from a nasal standpoint when they're reading or something like that. Obviously, going left to right seems maybe far-fetched, but if a patient comes in, you're doing an Amsler grid on them, they notice something, you can show them what's happening in almost a pictorial view. So these change analyses, I think, do a really good job demonstrating that to patients as far as what's happening with the progression of conditions over time. And this is, again, using FAF. It's FAF because it's a densely hypoautofluorescent blood vessel right there versus other technologies. Really, really useful in AMD. And in the left eye here. Let's see if I'm going to have to get this back to... let me see if I can actually play this. Well, that took that away. Let me go ahead and see if I can get rid of that laser pointer. Okay, sorry about that. So the other way you can do it is this flicker. There's this match flicker years ago that was useful for optic nerves comparing stereoscopic images to themselves over time, because trying to go back and forth, going clock hour to clock hour on a nerve, especially when we have OCT availability, seems inane. But this sometimes can really demonstrate the change here with just using flicker. So you can see how much that disease has advanced over a certain time frame. So again, you may have this on your different instruments. I just wanted to highlight that that's a good way for you to get a different perspective on things, because when you are doing something like this, and you can also do this back and forth on the individual slices, sometimes you are so delving into the minutia that you can get completely lost to what's happening grossly overview. So when we look at this, I want you to concentrate again on the EZ zone. You can see over time, over 4 years, you see a loss of the ellipsoid zone. You also see that the inner retinal tissues will dive in to the outer retina. And that's not good because obviously outer retina is atrophying, and those mitochondria are just dying in that area there. Same thing on the left eye. You can see that you have this hyporeflective area. What's interesting here is this is where they call it the Mueller cell cone. And the Mueller cell cone is essentially this cone, like an inverted triangle, that provides structural support. So in this condition, a lot of the time, the umbo, the normal structure will be maintained. As you have loss of these Mueller cells in this region, you'll have this cavitation because there's no fluid in there. It's just this empty cavity, and that will advance in this case as well. And they will call it an ILM drape. So the classification of type 2 MACTEL, which is what we're talking about, and we're going to talk about for a little bit longer here, requires multimodal imaging. And obviously I've tried to influence you a certain way, so I'm hopeful that this will be 100% as I'm trying to steer you, and it's fine if you disagree. But I really do think when we're looking at OCTs, we have to take our bias out and really try to understand the reflectivity and the various layers we're delving into and what those various layers do, and what cells are involved in those layers as well.
So Drew, I added to your question here. You don't see it, but
Okay.
I have the classification of type 2 MACTEL requires multimodal imaging. True, false, and then what is multimodal imaging? So
Yeah.
I know that, I sit through a lot of lectures. So Joe and I sit through a lot of lectures. When I first heard it, I think I understood it. Now I get what it is. But I think we toss that around like, multimodal kind of makes sense, but we're getting 5 responses here, going with letter C.
Yeah.
What is multimodal imaging? So you might want to
Yeah.
take
No,
a little deeper dive into what is.
Yeah, it's a great point there that I think a lot of times we'll say things from the podium that are just like, oh, it's multimodal imaging, and just kind of brush it off. And I touched on it a little bit earlier. In each platform, whether it's OCT or it's photographs, fluorescein angiography. Let's take, for instance, I won't name an instrument. Let's say it's an instrument that has the capability of doing fluorescein angiography, ICG, OCT angiography, near IR, fundus autofluorescence. All of those are various modes. Okay. And with fundus photography, that would be a mode as well. I guess you could argue a visual field is a mode. I think of multimodal as being more of a OCT imaging or photography, and we could argue as far as what the terminology is. So it's a matter of knowing you have this instrument, and there's these multiple tools that you have on these instrument, that if you use these tools in concert together, you'll be able to construct something that is a total understanding of whatever you think you have, present. It's like you construct it, and it's like, okay, I have reverse engineered what I thought is actually, happening. So I don't know if that was a good description or not. But that's.
I mean, I think I'll add to it, since we have 17% going with C here. What is multimodal? And the majority were true here,
Right.
of 70%, and then you have 13% false. But you kind of, in a sense, you've done it throughout your lecture. You talked about fundus autofluorescent, kind of targeting maybe that RPE area. And then you jump to your OCT, and certain things can hyperfluoresce, and then you have your photography. And you're just basically using each instrument to image the retina or whatever structure you're imaging, and knowing what you're going after in a sense. So FAF, I know you can do some vasculature or the inner retina, but typically if I'm going after, I'm going to see the RPE status.
Absolutely.
And so you're just using the different images for basically their sweet spot. And it might take multiple to kind of put the case together. It might have taken that photo along with the FAF, the fundus autofluorescent, and then the OCT, and you go, oh, with those multi images, now I know what this diagnosis is.
Yeah, I mean, you think of fluorescein angiography, and I think I'll probably talk about Donald Gass in a little bit. fluorescein angiography has its own language, and each of the individual diseases that are out there, the language of fluorescein angiography helps tell the story of each individual disease. And that's what multimodal does, is you're putting together different things to try to understand the language we should know and how that language, typifies an individual condition. And listen, there's a spectrum in a lot of these conditions, but understanding the language is really important. So if you have an instrument and there's different languages on them, you really should learn the different languages. And there's a lot of different resources out there that exist, but I think sometimes there are lacking basic OCT interpretation classes because it's a whole new language. It's a lot to deal with. So let's talk about MACTEL, historically called idiopathic macular telangiectasia. It's a disease that's actually a really theoretically rare disease. I think it's probably more prevalent in reality because a lot of times patients that have MACTEL also have diabetes, and I think sometimes we overlook MACTEL. Ultimately, it's can be a spectrum of a disease. It's not necessarily a continuum where just because you have a certain type or stage of MACTEL that you're going to end up with an end stage situation where you have macular neovascular membrane and loss of vision. Exact mechanism is not clearly known. They're working on that. And the classification historically was, Unuzi. Well, it was actually J. Donald gas off fluorescein. Unuzi, modified that a little bit, but only recently we have SDOCT and FAF or fundus autofluorescence involved. We use the term elderly, which is scary because I'm close to 50. Bilateral disease of the elderly, sixth and seventh decade of life. And regardless of what happens, there is a set space called the MACTEL area that is this 3 millimeter space that's centered on the fovea, and it goes horizontally 3 millimeters, 2 millimeters vertically, and it's exactly the same every single time. So it's kind of weird. It all pretty much highlights back to, and I think it's Müller in German. I'm going to call it Müller cells, but it all comes back to this Müller cell cone that is damaged. And when we think of the macula, there's multiple neurons or neural tissue that's going on. You got bipolar cells and you got ganglion cells and you got photoreceptors, but something has to be in there structurally, and that's where the Müller cells are. There's structural support as well as providing nutrient support as well. So it's this regional Müller cell loss, and that's why you end up having these cavitations. And you look at how it makes sense. This Müller cell right here, it's the blue one, and it goes from superficial retina all the way down into the deep retina there. So it makes sense that if you have damage in that area, that is kind of a continual thing that goes on, you'll have atrophy of the tissues around it. So you have this neurodegenerative situation, and then you have a lot of vascular tissue in those layers that are supported by the Müller cells, and so therefore you end up having this vascular compromise. And so when I showed the fluoresceins before, it wasn't this like blown up fluorescein hyperfluorescence where you have a really, really insanely compromised tissue that's inflamed or the vasculature is just completely shot and it's just completely leaking everywhere. That's why it's a little bit more of a subtle presentation, going back again to the different languages we use. So the main thing why this is probably an underdetermined or underdetected disease is a lot of people with MACTEL2 have diabetes. So when we have a diabetic come in, a lot of times we're lazy. And I don't think that it's necessarily bad to be lazy because 95 out of 100 times it probably is diabetic, but there's a certain behavior that MACTEL will show, and using the different modes of your different instruments will help you understand what you're dealing with overall. The reason that I said it used to be called idiopathic is as we have more genetic testing out and there's more sharing of these genome association sequences and different consortiums out there, we're learning more and more about it. And there are some loci that have been determined to be MACTEL individual genetic loci. So this may actually have a hereditary component to it. But again, I'm not at the point where I think that anyone that you think has MACTEL that you should go, sign up for prevention genetics, do, your retinal panel. That's not how I feel about it. You guys may feel differently about that. There's not a lot of guidance out there on this right now. And I think we could talk more about that. There is a thought process that there's an issue in serine biosynthesis. So if there's an issue with serine biosynthesis, what ultimately is going to get in trouble? And it's the theme of the night, the mitochondria. And if you don't have serine biosynthesis, ultimately you don't end up getting these sphingolipids made, and then you're not scavenging free radicals. The cell membrane breaks down, the mitochondria fragment, and you're in trouble. What's interesting about it is going back to the specific papillomacular bundle, but let's just talk about centrally in that MACTEL zone. There's a lot of need for energy. And this is a specific mitochondrial issue that occurs in the Mueller cells. And it's really kind of interesting here, just looking at those Mueller cells. And I don't think we need to get into that level of cellular stuff, quite frankly, but it's kind of interesting to me in trying to brush up on all this stuff.
Hey, Drew, I want to geek out a
Yeah.
little bit on this
Yeah,
Mueller
okay,
cell
cool. You want to
thing.
go back to this?
Yeah, I mean, you can leave it there. I just
Sure.
want to I just want to take it like a different path and
Yeah.
kind of tie something together here is that, every time we talk about diabetic retinopathy and I have students come in, they always say, okay, what are the signs of diabetic retinopathy? They'll say, dot and blot hemorrhages, exudates, microaneurysms, neovascularization of the disc and elsewhere. And they always lump dot and blot together.
Yeah.
And I don't like dot and blot being lumped together. To me, if you and it's about this Mueller cell, is that when someone has a dot hemorrhage and it's a little deeper in the retina, the limiting factor, like a flame shaped, is up in the nerve fiber layer and hypertension. It's a on the capillary bed, hypertension's on the arterial side, diabetes is on a capillary on the venous side, a little deeper down in the retina. You get that dot hemorrhage, you got the Mueller cell. But how does it go from a dot to a blot? Is your Mueller cell is dying. And a Mueller cell doesn't take a lot of energy to keep it alive. So if your Mueller cells are dying in diabetic retinopathy, and diabetes is nothing more than an ischemic disease, well, then you must have profound ischemia because it takes a lot more energy to keep a photoreceptor going than it does a Mueller cell. And if your Mueller cells are dying, then you go from a dot. How does it go to a blot? Your Mueller cells are dying, and if they're dying, you must have profound ischemia. All right, Caldwell, I think you're a little bit crazy. All right, so then what is the hallmark sign of ocular ischemic syndrome? It's a mid-peripheral blot hemorrhage. When you see those hemorrhages out in the periphery that are blot, you're cutting off the internal carotid and you have a blot hemorrhage because your Mueller cells are dying. So I love it that you're geeking out tonight on Mueller cells, but a little twist to it is that diabetes, dot going to blot, your Mueller cells are dying.
I love it, Greg. And so the dot, I don't think we got taught dot blots, at least when I was up at PCO. I think it was dot and blot. It was always separated out because of the various differentials as well. But yeah, you're right. So I have a dot hemorrhage, or I have an intraretinal hemorrhage. This is like when my student says there's a little bit of SPK. It's like, how long do you think the chronic inflammatory disease process has been going on for them to have a little bit of SPK? So yeah, you've had consistent and chronic damage that's going on there. So no, I love it, man. That's great stuff. And so again, getting into the Mueller cells and not requiring that much, but they require something and they have to support the rest of the tissue. So what'll happen is if the serine is breaking down, then you end up having a lack of free radical scavenging. You end up having lack of oxygenation, lack of energy, death, and then you have the subsequent breakdown. And it's really interesting here because they've done these post-mortem, they've got these eyes that have been donated that have MACTEL, and they've sampled Mueller cells outside of the MACTEL zone, which is what we have up top here. And the Mueller cell cell body is right about internuclear layer right here, and the cytoplasm will stain right here in blue. And when you have within the MACTEL region, you can see that you have all this space. The blue is disrupted outer plexiform layers. all expanded as well. And, this is, I don't think, they didn't give me a stage on this particular disease in MacTel, but it's all disrupted right there. So it's something that's very unique with serine biosynthesis in that MacTel region. And so it's a super, super interesting phenomenon that's going on right now. So let's look at clinical findings. I think you could probably make an argument that no, you don't need multimodal imaging, but I would argue that in current classification, you absolutely do. So there's this Lowy foundation, family foundation, and it's a prominent family that one of their members developed MacTel. And they went around, they finally got a diagnosis. It was misdiagnosed for a while. They said, is there a treatment for this? And it's like, no, there's no treatment for this. So they have sponsored this MacTel project over the last 20 years, trying to understand what happens in this, right? And these are the clinical things you might see. Loss of retinal clarity, which is thought to be the Mueller cells dying. It's almost like a precursor. You're saying, whoa, structurally, there's something off, that the overall transparency of the retina is off. The telangiectatic macular vessels, the blunted right angle vessels that my coworkers, it must have been board's review, are obsessed with the right angle vessels, which we'll talk about. So, I mean, this is the grayish parafoveal whitening, and I just want to go through these to highlight. If I have damage, and that damage extends down into ellipsoid zone, into photoreceptors, into RPE, what's RPE going to do when it's damaged? It's going to migrate. So a lot of times you'll have this reactive migration. And the thought process is that the migration obviously occurs from RPE, and then you have these blood vessels that will dive down subsequent to the RPE hypertrophy and even collateralize. The macular telangiectatic vessels, because you think about it, this was thought to be a vascular entity before, but it's more that the structural support is gone, so the blood vessels become compromised, and they'll essentially become telangiectatic. And it's easier for you to see on fluorescein angiography or OCTA. And I'm going to move on past that.
Right now, you're doing some multimodal imaging.
Yeah, I'm doing multimodal because really you look at just a color fundus photograph. Now I have injectable IVFA or a FANG, whatever you want to call it. And now I have a clean, normal parafoveal vasculature. And so you can see how there'd be multiple things going on. And you do have some diabetic changes on this patient overall. There's some thought process that MacTel can actually be protective, that patients with MacTel and diabetes have less retinopathy overall. That's a mild form of retinopathy there. So this blunted right angle vessel, this is multimodal because I'm going to do a color fundus photograph where if you can see my cursor, you can envision that blood vessel takes a right angle. I think you have to really open up your imagination there. Now, if I go over to me trying to sell fluorescein angiography, you can see that that's more obviously a right angle vessel, right angle vessel, right angle vessel, where they're diving in to that area of neurodegeneration and loss of those Mueller cells support. OCTA, non-invasive. It gets you the superficial tissue, the vascular tissue, and you can see that superficial vascular tissue diving in to this area that's known as the foveal avascular zone because there's no vessels there. And then again, so we have fluorescein angiography, we have OCT angiography, and then we go back to the fundus autofluorescence. And I didn't have a good FAF image, so I stole this from one of the Emily Chu articles here, where you can see that you have the parafoveal change right there, and then you see that kind of diving right over there. So this right angle vessel, it's like, why are these students and residents memorizing this? And why are people obsessing about it at work? Or at least we have been recently. I'm like, is this really a biomarker? So biomarker is a term that gets thrown out there. I did a biomarker talk a couple of months ago. A biomarker is just something that you see, in this case, an ocular biomarker. It's something you see in the eye that will give you information. It could be diagnostic information. It could be prognostic information. Typically, we use these as prognostic biomarkers. So something you see in the eye that may give you a clue of how this thing is going to play out. So can I use this right angle vessel as a prognostic biomarker for how things are going to go with my individual patient? And can I go ahead and address that accordingly? So these right angle vessels historically were these right angle venules, and they're associated with ellipsoid zone loss. Ellipsoid zone loss, photoreceptor loss, possible compromise to the patient's vision overall. So that's what it would look like. And the reality is that for the most part, clinically, if you see a right angle vessel, it's probably going from a pre-proliferative where there is no macular neovascular membrane to a proliferative where there is a neovascular membrane that could be injected. So if you see this right angle vessel, it actually is important overall. Because in this study right here, I go to the bottom here, 50% of patients with proliferative disease had this. Now, if you go in tomorrow and you start doing OCTA on every single diabetic and you start trying to create right angle vessels, you're going to drive yourself bonkers. Typically, it's pretty far advanced. There might be some RPE hypertrophy, and these vessels are pretty prominent overall. You can see them easier with OCT angiography. I'm going to move past this because I don't want to delve into it too much, aside from the fact that if you see a very obvious right angle vessel, it's going to be a problem. And that would be something more obvious, like something like this, where it's diving over like that. And you probably have parafoveal graying. You probably have crystalline deposits. You might have RPE hypertrophy. You might have cavitations on your OCT. So these crystalline deposits right here, there's always crystalline retinopathies that are out there that are potential differentials. Those are indicative of Mueller cell damage overall. I'm going to move past this because this isn't relevant anymore, in my opinion, because this was developed in '93 and remarkable. Everything that Donald Gass did, most of it has stood up even now that we have OCT. So the stuff he did with just using a 78 diopter lens and fluorescein angiography to understand the different disease processes in the retina is absolutely remarkable. But we now have SD-OCT, OCTA, and FAF, which all can help us get closer to understanding what Gass understood by just being incredible and working with what he did. So the MACTEL project has recently published a scale of what's important now with MACTEL with classification. And they care about the EZ zone. And a lot of times when these publications come out, it's because there's something in the pipeline that they need to measure. And they need to have something measurable to see whether that thing in that pipeline actually makes a difference. And so what we see here is this is an EZ zone disease. That's what's important. That's what's going to compromise vision. And that's what is at least in the pipeline being attacked and is now FDA approved. I do want to say one thing, and this is when we look at OCT. So when we look at OCT again, do not assume because there's hyporeflectivity or it's black that it means that there's fluid there, because you can have a neurodegenerative process like this that just has cavitation, okay? And also in a case like this, most of the anatomy of the umbo is preserved. You have this ILM drape. You can have either an intraretinal or an outer retinal cavitation. It is not fluid. So we have to be careful not to conflate the two, because if you have a case like a diabetes, like a diabetic macular edema, you can see that this tissue is not regular from a thickness standpoint. It is thickened. I mean, going back to the thickening from CSME years and years ago. Okay, the tissue is thickened, it's compromised, and there's actually fluid and exudation. That's a presence. So that's a DME. Okay, when we look at a chronic CRVO, ischemic CRVO, or probably an HRVO here, honestly, looking at it, we could take some liberties with that. I'm not sure what the exact diagnosis was on this, but it was a vein occlusion. And you have that loss of all that tissue here, but you have this distension of this tissue right here. And you can see in a lot of these cases, you have a little bit more of a haze going on. Whereas in a MACTEL case, what's the process that occurred? It's pretty much like you went in and just physically removed this tissue in a relatively precise manner. So just a food for thought on that. So when we talk about MACTEL right now, the important thing is what's happening with the EZ zone. So the EZ zone here, nice hyperreflective area right here. It drops off, it starts to dive off, it gets less dense. And then you have the diving of the interretinal tissue here, and then you have loss of tissue right there. Why is it important to look at this? In stage 1 and stage 2, it goes up to stage 6. Well, stage 2, you have central subfoveal EZ zone loss. And why is that important for us? Because by the time you get to grade 2, you have 15 letters on average. Once you get to grade 3, rather. So we want to be looking at these early on. And when you have easy breaks, you want to start watching these patients a little bit closer overall. I don't think we need.
And we always get thrown under the bus, Drew, for acronyms, not,
Oh,
in
yeah.
our
Sorry.
surveys. So
Yeah.
ellipsoid zone, but I also want to use it to say I need to jump here. I need to hop to
Okay.
another webinar. Great talk. Joe, I'll let you take over. And I didn't want you guys to be surprised if any polling questions come up, but also easy ellipsoid zone. You
Yeah.
might want to expand upon that. So
Yeah. Sounds good. Thanks, Greg. Appreciate it, man. Have a good night. So yeah, so like when we look at this whole thing, we're going to be talking EZ or the ellipsoid zone. It's critically important to see how that disease is progressing. And as we go on into stages 3 and 4, ultimately we end up with more ellipsoid zone loss, as well as when we look down at the bottom, a macular neovascular membrane there. And they changed that terminology a couple of years ago to be more inclusive, because not every macular neovascular membrane was derived from the cord. So you may see still, CNVM, you may see, which is a choroidal neovascular membrane, or you may see MNV, which is a macular neovascular membrane. It continues to change in the literature. It's hard to keep up with sometimes. But like going back to the right angle vessel, you're not going to miss a right angle vessel right over here. So just again, food for thought. Okay, so poll question 4, I have access to OCT angiography, and I use this technology frequently.
Okay, we are putting it up for you.
Okay, and I'm gonna wait for the poll question answer here. I think I'm actually gonna let me start moving on here because I have limited time left. I do want to get to that next case because I do think it has some good teaching points. OCT angiography, if you're using it, is based on motion contrast, and there's a different algorithms and different platforms. But basically, what you do is you are taking sequential B scans over the same area in the retina, and there should not be any movement in the retina. So the only movement that could be occurring if there's a difference between the image you get on sequential B scans over the same area would have to be coming from erythrocyte movement. So you do a scan, the erythrocyte is captured. You do another scan through the same area, it's not capturing the erythrocyte, so on and so forth. And ultimately, the machine will process that information into a brightness map that will give you volumetric information about the vessels. And that's pretty much what you're doing with OCTA. You are getting in vivo, living patient, moving around information about what's going on with the vasculature. And early in MACTEL, you can go ahead and look to see the most compromised level is the deep capillary plexus, which we're going to get into, which is right here. Okay, so cross-sectionally, the deep capillary plexus is compromised, and that's the internuclear layer. And the internuclear layer is where you have the cell bodies of the Mueller cells. So it all makes sense where you're starting to have the initial disorganization of the vessels around where the cell body of the Mueller cell is breaking down. So when we do OCTA, essentially what you're going to be looking at is a superficial. So essentially what you're going to do is you're going to take like a segment, and like say a segment here that goes from here to here, and you're going to pull that out. You're going to turn it on its side. So it's able to give you information focused on individual plexi there. So what you're going to see here, and you might capture things early, is you can start seeing down at the bottom in this deep capillary plexus, or the vasculature that is abutting the internuclear layer, you start seeing some dragging that's going on there. And even more so as it gets advanced. The visual consequences can be, problematic. Obviously, depends on what you're using. Microperimetry is going to be more sensitive. Snellen isn't always the best for these cases, but there can be visual consequences overall. So what are our treatments? If I get to the point that I use my OCTA, and I use my OCTA to isolate this area right here, which is the outer nuclear layer, and is the deep capillary plexus, or is supposed to be avascular. What I'm going to end up having is if I have vascular tissue in that area that's supposed to be avascular, most likely I have a macular neovascular membrane. So that is amenable to injections with anti-VEGF. But if I just have EZ loss, like we have here, then there is a new medication out called Incelto that will actually slow down EZ loss. There's also some thought process given the serine biosynthesis issues, as well as the formation of these deoxysphingolipids that are found in about 84% of MACTEL cases, which end up just causing a lot of dysfunction with mitochondria, that if they supplement serine and they use fenofibrate, there's a possibility that things could be slowed down. Those are in trials right now. There's not any proof that you could supplement a MACTEL patient and have value right now. So when we think of this in CELTO, it's a ciliary neurotrophic factor. And there's been studies that have shown that that's really important in your retinal cell differentiation. And if we can help to put that into the eye at the area that is getting damaged, maybe that cilioneurotropic factor may actually jolt things back to life. I'm going to move past this. So what is out now is this encapsulated cell technology, where essentially they have these genetically modified biomolecules that will end up being able to be placed into a membrane, and that membrane is then housed in an implant, and then it is implanted, and then the membrane is semi-permeable. So the medication, or not the medication, the genes that have been developed specifically in this case to help MACTEL will constantly go ahead and secrete the neurotrophic factors to help and improve things. And so that's the long and the short of that. And so this is what it looks like right now is you have this NT501, where you have this scaffolded here, genetically modified molecules that will go ahead and provide ciliary neurotrophic factor, and it will be constantly secreting. And it's done in a way where this is biocompatible and is not attacked by the eye once it's implanted. Those are just some illustrations of what the implant looks like post removal, where the ciliary neurotrophic factor producing genes are the same throughout. And this is what is out now. It's this Encelto. And essentially what has happened is they will go ahead, and I'll show you in a second, it is implanted into subsclera and sutured into sclera, and then it will ultimately release medications. The studies show a 54.8% slowed rate of EZ loss overall. Now, I want to just mention that when we think of like AMD, you look at this rate here in the sham of 0.166. AMD moves, geographic AMD from extrafoveal to subfoveal moves usually about 2.5 years, and it moves anywhere from like 0.5 to 2.5 in a year. So this is still a slow moving disease, but it could be slowed down overall. And so there's this new implant out called Encelto that is going to be available in June. The problem with this, as a lot of these orphan drugs, we're talking about something that's going to cost anywhere from $500,000 to $2 million. So just some food for thought on that, since we now have something FDA approved on MACTEL. But use the different facets of your different machines to make sure you're not calling this diabetic retinopathy. There's not a lot of guideline right now on when do I send out to a provider for Encelto. I think this is the same conversation with Syfovre and avacetocaptid pagol, where it's like, do you want to wait to see what the disease is doing, or do you just start injecting with impunity? So this is going to be, I think, a fairly niche product overall, but I did want to discuss it. Joe, you got any comments?
No, I thought you covered it very well. It's a very good introduction to this. When you talk about the geographic atrophy drugs, that itself is a hard sell, because what I hear from patients is, well, it's been stable, so why do I need to do this? Well, the answer is because it doesn't necessarily remain stable, but they think that they're doing all right, and they don't want to commit to those those monthly injections for a year.
Yeah.
So,
and the burden is different, right? If you're looking at 12 to 24 months, or arguably 36 months, to know whether or not you're actually having a yield on some of these complement inhibitors, the uptake cost and the burden of having something sewed onto your sclera is major. But this is something that will be bioactive upwards at least to 24 months, as far as the studies have been so far. So if that's something you could implant and it's a one and done thing, it may be less burden overall in a case like this, but only time will tell. We're going to move on to Bay State. So Bay State is, Massachusetts. I'm a New England guy, and I always look at people's social security numbers because when I was in private practice, one of the practices was near a Navy base, and I always knew if I saw a social security number that was under like 150, it was a fellow Yankee, and they were probably going to be a pain in the butt. So I would always go in and gear up. So this guy's got like an 025, so he's from Massachusetts. So I go in thinking, how's this guy going to be? Well, so the resident actually sees this to start, and I go in later on. Patient complains of bilateral blurry vision because they lost their RX, right? It happens. This guy's, pretty normal, 5'11", 185. He's got a history of pigment dispersion syndrome, which I question when I look at his refractive error. So I don't know if that was a mistake. He's got a history of a lot of cardiac issues. Recently been put on amiodarone times 5 months. The SpecRx is super high hyperope, which is very, very atypical when we think of the reverse pupillary block that occurs in pigment dispersion. So, I don't know. I'd have to look at this guy's cornea again. This is what's in the note. I'm somewhat skeptical, but he's got verticillata from being on amiodarone, which is very common after 5 months. Supposedly has mid-peripheral TIDs. I believe it when I see it. This guy's got a history of 0.5 CDs, which becomes relevant. We look at his nerves. I'm going to blow them up here, and we use a couple of different ways to do this. Clinically, he has superior edema, inferior hyperemia on this left eye. So there is compromise to these nerves. Most likely, there's obviously been some stasis occurring. Who knows what's happening at the level of Brooks membrane line. But we're presuming with the cardiac issues that this is ischemic in nature, bilateral. Note that the CDs are minimal on the left and minimal on the right overall. Let's look at the RNFL. And, if I bisect this in half, if I just go, top half to the left, bottom half to the right, I may not be overly wowed by this. The clinical fundoscopic evaluation is absolutely critical here, obviously. From a reference database standpoint, it's enlarged, it's elevated. Is this potentially, be normal for this patient? Yeah, but you can see the caliber of the tissue here, just how hyper-reflective and clean this is, whereas this is less hyper-reflective. The overall brightness is diminished here, and that is distended tissue. There's no question mark whatsoever on this left eye that both the inferior half and the superior half are distended, and substantially so. But when we go back to the photograph, it's like, this is not really that swollen overall. So I think it's a matter of, perspective sometimes, where sometimes we get to the OCT and we freak out. But I do think the clinical fundoscopic evaluation is absolutely, like I said, critical. Again, we talked about neural tissue, and we talked about where do the axons come from that make up the nerve fiber layer and ultimately hit the neuroretinal rim and then dive down through lamina to get to chiasm and then the optic tracts, synapsing back there. Well, they start in the ganglion cell. So we look at this, and you don't have to know entirely how to interpret this, aside from the fact that if you look at the numbers, the symmetry is actually pretty good. Hotter colors are thicker, but the symmetry is pretty good. There is no edema in that area, so you can use this as a biomarker of function at that time. We went through Vindich MD earlier, so let's say we went through all these circumstances that I had before, and what do we say? We say we have a bilateral optic neuropathy. Is this thing simultaneous? Is it happening at exactly the same time? Is it asymmetric and simultaneous? Or do you have some sort of sequential thing playing out? Because I can't go back in time and figure out like how this thing is playing out. I'm just seeing what I'm seeing. And so this is what I'm doing, but I'm presuming it's ischemic based on the information we have overall. So we have this bilateral sectoral optic disc edema. It's OS greater than OD, and we talked to him about all the various etiologies. Order an MRI with and without contrast, fat suppression within 1 week to rule out space occupying lesion. We talked about stir and fat suppression. And do I think we have a bilateral optic nerve head glioma? I think that's insanely far-fetched. So did we need to go to this extreme? I think we could make I think we have different conversations on that. Then we order blood work, and it's like the blood work with impunity. We're going to do Lyme titers and syphilis on this guy, and TB and ANCA and ANA. And we did this. I mean, this is on me. And I think I'm a reformist with, did it make sense to do this? Going back to, are we doing a diagnosis of exclusion, or are we doing things that make sense to match up with the disease that we think is going on, because we have a pretty good idea of what's going on? And then to Joe's point, the field should have been done that day. I'm not sure what the circumstances were, because I think it was like, let's get some blood work to rule out GCA immediately. And I think that may also be a little bit on the cautious side. And then we alert cardiology. So is all that blood work necessary in this 59-year-old guy with all this cardiac stuff that's completely asymptomatic and appears to have something that is not necessarily acute, depending on how we define things? I think in general, there can be different ways in presentation of an AAION. And you always want to make sure that even in this age group, and I think it's been lowered with the guidance, you want to rule out GCA. So I think that's reasonable. The Lyme titer is insane. When we look at Lyme titers done even in Lyme endemic areas, there was a study that showed it was over $500 million in unnecessary Lyme testing done. So Lyme can affect the entirety of the eye, but you're not going to have Lyme disease, bilateral optic neuropathy without anything else going on, cells, something else like that. So that made no sense. This guy's not a hiker. We're in Tennessee. That's not endemic. ANCA, this guy doesn't have a vasculitis that's going on, so that was unnecessary. The likelihood of a lupus-associated optic neuropathy devoid of anything else, hemes, cells, isn't there. Syphilis, I think you could argue. We've got a couple of good SIF cases, and when we look at syphilis, when you have neurosif, the eye ocular manifestations are usually a posterior with some inflammation spilled over elsewhere, or you have a panuveitis. So that didn't make a lot of sense either. Shockingly enough, Lyme came back negative. So I do think that we would have expected that some of these tests we did to not come back in a positive way. So this is just talking about when you do testing, unless you really are, I have no clue what's happening, and I understand I have no clue what's happening. I'm just going to order every test, understand that maybe some of those tests will come back positive, some will come back negative. You really want to do selective testing as much as possible. And there is context, because you do have this relatively acute monocular scenario playing out. If it was chronic and unilateral, there was a study done up in Toronto a few years ago that if they come in, they have a unilateral pale nerve, you doing a whole bunch of testing is probably not going to yield that much overall. And the only thing here that was found in the MRI was a planum sphenoidal meningioma. And I covered that in Neuro Rounds 1. And most likely those patients will have reduced vision. So just food for thought. When you're doing testing, try to do testing that makes sense overall. Ultimately, his brain scan was completely normal. I'm going to push past this. When we look at visual fields, you have a superior arcuate in the left, a inferior arcuate in the right. When we go back to Hayray's studies on NAAION, which maybe we're pushing down the path of for right now, that this is a sequential event, there were 84 different field defects. So we are taught certain things to memorize for tests, but the reality is the studies don't always match up with that. So this guy's got these arcuates. Now, the guy wants to know, hey, am I going to lose vision from this? Am I going to apply NAAION stuff to this? Well, yeah, because I don't have anything else. Maybe that's not the best way to approach this, but this is what we have. So a good percentage of patients that presented with pretty good vision, after 6 months and out to 2 years, these patients ended up having good vision at the end. But can we even apply this here? Are we looking at this correctly? So question 5, as we wrap up here, macular testing can provide prognostic information in patients whose optic nerves are swollen. So we can go ahead and run.
We're down to about the last 4 minutes. Do you want to do the polling question?
No, if you guys are good, I'm just going to move on, because I do want to make that point. Yeah. Again, as I said before, from a prognostic biomarker standpoint, it's really, really important to always go ahead and do that macular scan. Anytime you do nerve, you do the macula. Okay, that comes to glaucoma, that comes to swollen nerves, any of this stuff, because you want to understand how bad that neural tissue is being damaged. the GCIPL, ganglion cell interplexiform layer, ganglion cell complex, isolated GCL, any of these can be compromised at 2 days post-event. Okay, so you can go ahead and look in there when the nerve is still swollen and you can't tell what the heck's going on, and you actually can get prognostic information from the GCIPL. So this is a good example of a case where you look right here, both the superior and inferior aspects of this are still swollen. The isolated GCL, and this is at day 1, appears to be symmetric both superiorly and inferiorly. At 1 month, you still have a relatively normal caliber superior amount of tissue here, but that ganglion cell complex, which is the ganglion cell complex cells that create the axons that go into this nerve up here that show over here, are already shot. Okay, and you're going to have a field cut overall, and it's going to be a precursor to ultimately what ends up happening here. Okay, so you see that that's gone at 1 month. At 3 months, you end up the nerve fiber layer is completely done, but it was swollen for so long that you wouldn't know. So that person is going to have a field cut, and they're going to have a field cut and loss of visual sensitivity inferiorly, and that may be something that's impacting their reading. So you may know early on based on looking at their GCIPL. GCIPL can be also useful to try to forensically determine whether you had an NAION, which does tend to be more altitudinal, but it depends on how the choroidal infarct occurs. You can have more of a diffuse pattern with optic neuritis. If you have a compressive situation, you can have a binasal loss of tissue there, where you have a chiasmal thing. And then I threw in a retrograde dieback case where this patient had a left infarct overall, and there's a thought process that the axons can die back up into the eye, and you'll end up seeing a defect as well, where you end up having, this is a left-sided loss of tissue here, where you have a left-sided loss of macular tissue as well as a retrograde dieback. And again, that's another talk for another day. So our case, ultimately, you saw, looking at his GCL from August to September, you can see a big drop off numerically here from 39 to 21. And then ultimately there is a loss there. His visual field ultimately ends up not being that terrible. This was the final field. This is what he started off with. And then he returned to baseline on the cupping. This was not cupping that was some sort of a glaucomatous thing. This is what he ended up being at all. So ultimately what we found here is that he behaved, and I'm going to move on past this, in a way that's similar to an amiodarone optic neuropathy, which is a very, very rare occurrence. There are some that don't believe it actually exists as its own entity because these patients have all these vascular risk factors consistent with an NAION. Ultimately, he was taken off amiodarone. It can be a very, very toxic agent, going back to the mitochondrial optic neuropathies to start. And ultimately, he was put on a different medication to try to manage his atrial flutter. And I think that's where we are at. So you do have to consider these things overall. But I'm done for now.
Drew, I had an amiodarone neuropathy within the last 2 to 3 months. Yeah, it does exist. It is its own entity. It is not terribly common. Don't worry about the verticillata. You need to worry about the optic neuropathy. Now, what makes me believe that you are correct that the amiodarone was the culprit here is the bilaterality.
Yeah.
Not, first off, 0.5 CD ratio, a little bit too large for non-arteritic.
Yeah.
You never diagnose a simultaneous non-arteritic. I will give you one example. The one time I've done it, and that was within the last couple of months, it was a person who lost 7 units of blood.
Okay. So it was a hypovolemic situation.
It was severe hypovolemia because non-arteritic is bilateral sequential only in 15% of cases at 5 years, and it happens on an average of about 30 months. So the fact that you had some bilaterality simultaneous, even if there may have been one that was ahead of the other time-wise, it wasn't 30 months ahead, tells me this is by far likely an amiodarone toxicity, which can mimic non-arteritic ischemic neuropathy. And by the way, I am working to redefine that term away from non-arteritic anterior ischemic optic neuropathy because too many things fall into that diagnosis of convenience. I'm starting to call it small vessel anterior ischemic optic neuropathy. So not NAON, it's VAON.
Yeah.
So if you stop sharing your screen, I'm going to wrap up for us. All right, all right, all right. So we're going to wrap up right now with this is our final presentation final for tonight. You're going to see up here we have the little red button. That is our survey. We are ready to take that now. You can take it later or you can start taking it now. So that was fantastic. Optic nerve and retinal rounds, nerve-wracking to nuanced. I'm sure you have a lot more cases, don't you, Drew?
Oh, yeah.
So I'm sure we're going to be having you back. I think that was fantastic. Greg was very helpful with his comments. He had to jump off for something else, but I'm happy to finish hosting you and bring this one on home.